Hi, everyone. My name is Ahmad Masri. I'm a cardiologist and an amyloid specialist at Oregon Health and Science University. It's great to join you today, and I would like to thank Mackenzie's Mission and the Amyloidosis Speakers Bureau for inviting me to talk about do you need a heart biopsy to diagnose cardiac amyloidosis? And this is an interesting topic. You'll see that the focus is the clinical question, not actually the approach to doing a biopsy. I think that we can leave it for some other time. Those are my disclosures that they should not have really anything to do with the talk today. And so just a quick overview. I know many of you have heard about this over and over. The traditional approach to amyloidosis diagnosis typically used to rely mainly on symptoms, presentation from the patient, electrocardiography, echocardiography, with more recent, in the last decade or so, routine use of strain imaging, which tells us how these walls are moving in the heart, and MRI, which is increasingly being used in the United States, but not as much as it actually should be. And so when you put all of these together, historically, this wasn't enough because only patients who really look like they have significant burden of amyloid end up getting to the confirmatory diagnosis. And at the time, the confirmatory diagnosis was really, largely speaking, an endomyocardial biopsy, or what we call a biopsy from the right ventricle or the septum from the right ventricular side. So the biopsy, we don't go to actually to the left ventricle. I mean, sometimes we do in other diseases, but in this one, we can just go to the right ventricle through the neck veins and get some tissue from there. And so that all has changed, over the last few years and, more than a decade now by the introduction of bone avid tracers that can be repurposed and used for myocardial imaging. And here you can see this is a single injection of a tracer. It's a bone tracer, so bone lights up in a negative scenario. In a positive scenario where the heart is taking this up, you can see how the heart is taking it up. And the important piece of information is that you need to do SPECT imaging, which is a way of really just doing three-dimensional imaging. You want to look inside the chest to make sure that this overlay is not just being, whatever in front of the heart or the blood pool or anything like that. You want to see that it is actually in the heart itself. And so over the years, many centers have used that, but really the pivotal point was back in 2016 when this multi-center study came out and said, if you have somebody with suspicion of transthyretin amyloidosis, high enough suspicion, and you rule out light chain amyloidosis, so these are the two common types, as many of you are aware, then you can have a very high specificity and sensitivity for this diagnosis. However, it's extremely important to not forget that the workup for light chain amyloidosis relies on serum-free light chains, immunofixation or immunotyping, and checking the urine protein creatinine ratio and NT-proBNP and troponin to give you a holistic view or picture of what's really going on with the patient. And once done, and this is for a lot of our internal medicine and hematology colleagues, once done ruling out light chain amyloidosis, don't forget transthyretin, because we see a lot of the times that hematologists sometimes work up for light chain and then they tell the patient you don't have systemic amyloid, but really the patient just has isolated cardiac TTR at that point in time. And so also, if you see a lot of patients who have monoclonal gammopathies, remember that it's not just looking at the monoclonal gammopathy. Try to get into the habit, especially for patients above a certain age, to look at the urine protein creatinine ratio, looking at NT-proBNP, and then looking at really EKG and echo if someone has any symptoms with this disease. So what I wanted to show you here, just quickly, our approach here locally at our center. This is similar to many of the guidelines, but it's actually slightly stricter here. The reason why we do it stricter, because we get so many referrals, not just amyloid, other types of cardiomyopathy. So you really want to be strict on how you define things. So we already talked about how we go through the light chain pathway. Now for the transthyretin pathway, if you have a classic presentation and you have what we call like diffuse grade 3 significant uptake on SPECT imaging, and there is no AL whatsoever or any suspicion for AL or high-risk MGUS, then you're done. You have transthyretin amyloidosis, and if you have a reason to suspect other rare amyloid, then you need to think about that. On the other spectrum, on the other hand here, if you have MGUS or someone with light chain amyloidosis, but you really think that they could be very high risk for TTR. So take the example of someone who's 85 years old, doing amazingly well. You think they have AL, you really need to make sure that they also don't have TTR, or they actually just have TTR and the AL picture is just a very unusual, aggressive looking MGUS that is just in the blood, and they don't actually have tissue involvement. So in this scenario, and I'm not suggesting that you should do this, this is just should be done like in a selective case. In this scenario, if you like us, where we do the AL and the bone scintigraphy workup all at the same time, then you can use that bone scintigraphy to guide you sometimes. You can't use it to diagnose TTR if you have MGUS. So if you have MGUS or AL, you can't use bone scintigraphy to diagnose diseases. But it can give you a clue. If someone has a positive scan, then you should go to the endomyocardial biopsy, because simply you cannot tell if they have TTR or AL. But the stricter approach that we have is that if you're doing, if anything other than grade 3 planar SPECT uptake on TTR imaging for bone scintigraphy, we need 2 imaging test approach. So we typically do the PYP or HTP with a CMR, and we do TTR gene analysis. If we can do CMR, that's where we rely more and more on endomyocardial biopsy, because we don't want to really be diagnosing patients with cardiac amyloid if they have grade 1 or grade 2 uptake only. Grade 2 is a little bit more reliable than grade 1, but we have seen enough cases where it's really not that all the story. So just being careful there. And so for AL, you can use cardiac MRI to give you a burden of disease at baseline and then during follow-up as well as needed. But if your echo is classic, if the picture is classic, you sometimes don't even need cardiac MRI really to do this. So now, I want to give you examples of when to use endomyocardial biopsy. So I already told you that you use endomyocardial biopsy when you're not sure what type of cardiac amyloid you have, when you have an MGUS that is suspicious for light chain amyloidosis, but you don't have exact confirmation that the heart is involved with light chain amyloidosis. And you do it also when your imaging is inconclusive. So that's where the stories and scenarios we would be doing it. Look at this example of someone who has shortness of breath, who has LVH on echo, who was sent for pyrophosphate scintigraphy. You really can't tell whatsoever if the scan is positive or negative. A positive scan, as I showed you, should have really, the septum should light up. I'll go back actually to show you. This is a positive scan down here in the left corner, where the septum is lighting up and then the blood pool is empty and then the lateral wall is lighting up. So pretty nice image there outlining the heart. Here you don't see that. So I don't want people necessarily to rely on something like this and say, well, this is negative. We don't know if it's positive or negative. So what we do sometimes is that we repeat the imaging using a more sensitive tracer called HTP. And in this scenario, the HTP is positive, showing you there is no uptake in the blood pool and showing you there's uptake in the septum, which is that pinkish color. But it is not classic. It is not very strong uptake. And as such, before committing someone to a drug that is $275,000 a year, like tafamidis, we really want to be sure. So that's a scenario where we do an endomyocardial biopsy, which we did in this case, and it was positive for amyloid, which is a good thing in the sense of it confirmed our suspicions here, and we did not just dismiss the patient based on this case. Another example, this is published by one of my colleagues, Matt Moore at Columbia, and Dia Smiley as well, showing a 64-year-old gentleman, African-American, who has V122I, has HCM, hypertrophic cardiomyopathy picture, obstruction, gradient, everything. So you might say, well, I'm done. There is HCM. I'm going to treat the HCM. But the patient underwent genetic testing and has V122I and is an African-American. The MRI was not really much revealing. You can argue there is a dead cell of late gadolinium enhancement down here, but it's really not convincing on its own. And so this is a scenario where the patient underwent endomyocardial biopsy, which shows you the classic positively birefringent amyloid deposits in here. That essentially tells you that the patient does have cardiac amyloidosis on top of having obstructive HCM physiology. So they don't necessarily have hypertrophic cardiomyopathy, but they still have the obstructive physiology that sometimes you really have to treat anyway. And then, just a plug-in for a newer imaging agent that we use called ivazimutide, where it was positive in this case, even though the pyrophosphate scintigraphy was negative. Another example where you need to keep an open mind, this is not to confuse you, but I want to tell you how endomyocardial biopsy is important. This is another African-American gentleman with V122I, which is a causative mutation for amyloidosis, not in everybody, but in some patients, who presented with a profound presentation of being ill. And then the PYP was positive, but it wasn't classic. You see here, there is only uptake in the septum. The lateral wall here looks exactly like the septum, yet there is no uptake here. And when I saw him and talked with him, by the time that I saw him, he was doing so much better than this acute presentation. So I told him, you know what, I actually don't know for a fact that you have transthyretin amyloidosis yet. You might develop it in the future, but I'm wondering if this PYP scan is a false positive PYP scan. So we went ahead to do an MRI. MRI, unfortunately, was refused to be done at our site, so was done somewhere else, and the quality is iffy a little bit. But you still see there is no big amount of light up on late gadolinium enhancement, which tells me that I'm actually on the right path. I don't think there is amyloid in this scenario. And so we went ahead and did endomyocardial biopsy, and we're very, in terms of the evaluation, we're very careful. We do typical H&E staining, but we also do electron microscopy, which is great for picking up small amounts of amyloid because you can just see the fibrils with your own eyes without relying on any staining. So we do this is not routine in everywhere, but we do this here to be more careful. And the endomyocardial biopsy was negative, which means that the patient, even though had a presentation that could be amyloid, does not actually have cardiac amyloidosis yet. And then finally, I'll end with this case, which is too many pictures, but none definitive for a diagnosis. This is an example where the echo showed some left ventricular hypertrophy. The patient had long-standing valvular disease, so you can blame that on the hypertrophy. The patient had some like lateral late gadolinium enhancement, not a lot in the septum. You can blame maybe the valvular disease and being undergoing open heart surgery for this, like fibrosis here. Then the PYP just shows like two patchy spots of uptake. So really, and then the AL workup wasn't positive. And so really, you don't know for a fact that this patient has amyloidosis or not. So in this scenario, you have enough to treat if you want because there is uptake here, but we really want to always to be more knowledgeable about this. So that's a scenario where you would do endomyocardial biopsy to confirm that the patient has transthyretin or light chain amyloidosis or whatever amyloid disease they have. We also have access to an investigational tracer called ivazumutide. It's a PET tracer, allows us to image multiple organs. This is the same patient, shows you how diffuse the uptake is on ivazumutide. Compare this to PYP, how patchy it is. So PYP is not perfect. That's why we still need endomyocardial biopsy in some patients. And then you can see how the patient has significant joint involvement, including carpal tunnel involvement, shoulder involvement with this disease, the bladder, the GI tract, and the stomach, and the salivary gland, and the thyroid. These are normally distributed for this tracer. So I'll conclude here that while imaging and non-invasive workup advanced significantly our ability to diagnose cardiac and systemic amyloidosis, there still remains a large unmet need, in my opinion. We need new imaging techniques that allow us to image non-cardiac structures as well. I am interested in imaging the kidneys, the liver, the spleen as well, so that we advance our understanding of light chain amyloidosis and other rare amyloid diseases. Endomyocardial biopsy is still required in about 10 to 15% of atypical cases, or in situations where one needs to exclude more than one type of amyloidosis, which happens, especially if you have an elderly person with renal light chain amyloidosis. Make sure that the heart is light chain and not TTR concurrently. The most common indication right now is when you have concomitant MGUS and high likelihood of ATTR cardiomyopathy. Most typically is older individual who is doing really well clinically. And then in centers with expertise and frequent use and imaging guidance, endomyocardial biopsy is really safe in patients with left ventricular hypertrophy. It's very, very safe, very infrequently that you would get into trouble. So thank you for listening and for watching this, and looking forward to further encounters later on.